Greetings to all. Today we will be discussing a very important topic, that is asthma. So let's move directly to the definition. So what is asthma? Asthma is a chronic inflammatory condition. Chronic inflammatory condition of what? Of airways. Chronic inflammatory condition. So there must be chronic inflammation that is resulting into hyperresponsive airway. So the airway is hyperresponsive because of chronic inflammation ongoing to what? To different triggers. So what can be the triggers? It can be different kinds of triggers, such as it can be like pollens, it can be dust mites, it can be indoor and outdoor pollution, isn't it? Or it can be like fungus or molds, it can be like cold air, it can be like smoke, it can be like food particle allergies, or it can be exercise induced, it can be stress induced, it can be like pains, or it can be occupational asthma. So these are the different types of triggers, and so on many other things. So these are the triggers. So what will be there? There will be chronic ongoing inflammation of the airways, which results into hyperresponsive airway because of the triggers, and these are the different types of triggers or stimulus that results in reversible bronchoconstriction. So what will be there? There will be reversible bronchoconstriction, and that reversibility can be self-reversible, or there may be need of medication. And these all phenomena are manifested as wheeze, cough, chest tightness, and there can be breathlessness. So these points help you to define asthma. So asthma is a chronic inflammatory condition of the airways which results into a hyperresponsive airway because of the triggers that results in reversible bronchoconstriction, resulting in wheeze, cough, chest tightness, or breathlessness. So you have understood this. Now we have to clarify a bit more on these symptoms. So these symptoms usually manifest as diurnal variation, and by that it means these are mostly more common at nights or early mornings, isn't it? So this thing you must keep in mind. And there is presence of episodic presentation of the symptoms. Episodic or seasonal variation can be there, or it can be triggered following any kind of events such as exercise, or it can be like stress, or based on the different stimulus or the triggers, the manifestation of the episodes can take place. Now let us discuss the different types of clinical features of different clinical features of asthma. The most common being the wheeze, and that wheeze is also expiratory wheeze. and this is most commonly manifested during forced expiration. So you put on a stethoscope and you ask the patient for forced expiration, then you can hear the rustling sound of air, and that is called as wheeze. And one thing to be kept in mind is that suppose there is a patient and he has the symptom of wheeze, and gradually there will be wheeze, and suppose let's say because of mucus plug in the bronchus, suppose this is the bronchus and there is the mucus plug, and during expiration when air tries to escape, because of this obstruction there is wheeze manifested. But sometimes when the mucus secretion is severe and the bronchoconstriction is severe, then what will happen? Then the airway becomes closed. So because of that the air cannot escape. So in case of severe asthmatic episodes, the wheeze can be absent. So you have to keep that in mind. So during the time course of treatment also you have to keep this thing in mind, because suppose there is severe early you can find wheeze, and the baby or the patient might have gone to severe wheeze or severe asthma, then wheeze will be absent. But if you start medications, then it will be bronchodilation. So it will be bronchodilation, and then again air can escape, so again wheeze is manifested. So you have to keep that thing in mind. Suppose if there is wheeze absent but there is signs of respiratory distress, then you have to think in mind that the case is very serious. So this thing you have to keep in note. And another commonly manifested is cough. Initially the cough is dry cough. And there are several bouts of cough, and it is mainly manifested at night times. So there will be paroxysmal cough, and they will cough like and at the last they will produce sputum. So initially it will be dry cough, and as the disease progresses it will be converted into productive cough, isn't it? So that's clear. And one thing you have to keep in mind, that another one different type of asthma, it is called cough variant asthma. So in this kind of asthma, what you will find, there will be only cough, and you will be finding the signs of hyperresponsive bronchus. However, wheeze may not be present, so you have to confirm it by pulmonary function test. And another is chest tightness, and there can be breathlessness and other clinical features. In case of severe asthma, what you can find is that signs of respiratory distress, such as use of accessory muscles. There can be like nasal flaring, there can be chest ingrowing. And another thing to be kept in mind is that suppose you find the patient is drowsy, unconscious, and there is absent chest sound, then you have to keep in mind that this condition is very much very severe, or it can lead to asthma related death. So you have to be very quick to pick up these patients. And if there is ongoing asthma and there is ill management, then after a few years, after gradual years, then there can be barrel shaped chest. So these are some of the clinical features of asthma, and these features can be episodic, it can be paroxysmal, or there can be seasonal variation, or based upon the triggers there can be clinical manifestations. Now let us discuss the pathogenesis of asthma. Suppose we are talking first of all about atopic asthma, which is like pollen or allergy derived asthma. So in lungs, so this is lung. So in lungs there are dendritic cells, or they act as macrophages, and they present those pollens. Suppose this is macrophage and it has pollen in it present it to T helper cells. So this will be our T helper cell. So initially the helper cell, they are naive. Naive means they are not known about the antigen or the pollens, and now after presenting this they will become primed, and because of presence of interleukin 4, interleukin 5 and interleukin 10, they will be converted into T helper 2 cells. And these T helper 2 cells, again they produced interleukin 4, and this interleukin 4, what they will do is that they will produce IgE. They will give signal to produce IgE. Initially IgM is being secreted, then there will be class switching and IgE will be secreted, IgE antibody, and then interleukin 5 they will recruit eosinophils. Now what will happen, these antibodies they will get attached with the mast cells, and this process is called sensitization. Now the thing to be noted is that suppose this person again goes to that farm and gets inhales that pollen, then what will happen, these pollens will again be presented, and these pollens now when they get attached to the sensitized mast cells, then what will happen, there will be degranulation of the mast cells, and because of degranulation histamines will be released, and these histamines it will cause bronchoconstriction and vasodilatations. There will be release of proteases which causes proteolytic effect, and there will be ongoing inflammation. So there will be ongoing inflammation, and this process is known as early phase reaction. Early phase reaction. So 6 to 8 hours time period after second episode there will be early phase reaction, and in late phase reaction there will be eosinophils, neutrophils recruited. More importantly, there will be leukotrienes, and most commonly leukotriene B4 and leukotriene C4. So what they will cause, they will again cause more bronchoconstriction, they will uplift that constriction process, and they will be causing recruitment of more other inflammatory mediated cells, more macrophages, more neutrophils, more eosinophils, and all this process they get flare up. So all this process will go on continuously and continuously. So because of this, what there will be taking place, there will be bronchoconstriction, and there will be airway narrowing, there will be mucus plug, and because of all these phenomena going on, there will be features like wheeze, there will be features of cough, there will be features of breathlessness. So those clinical manifestations will be seen. So this is the pathogenesis for atopic asthma. So there are different other types of asthma as well. For example, there is exercise induced asthma. So what will happen in exercise induced asthma? During exercise, what will happen is that at the time of expiration there will be loss of water. During expiration, because there of heat genesis and because of rapid expiration there will be loss of water, and because of this loss of water it will trigger immune mediators, and because of that the process of asthma takes place. So this pathogenesis has been forwarded for exercise related asthma. And another is occupational asthma. So suppose there is a painter, so because of that paint sprays that can also trigger to asthma. So this is another thing. And other types of asthma, like there can be genetic predisposition, family hereditary predisposition, and genetic likeliness can be there. So these things also need to be kept in mind. So these are different things that have to be kept in mind. And another thing, we have to be very much conscious in case of pregnancy and pregnancy related asthma. So suppose if a pregnant woman is asthmatic, then we have to keep that in very much mind and work out cautiously. And so these are different pathogenesis that are linked with asthma. So the thing to be kept in mind is that type 1 hypersensitivity is most common, type 1 hypersensitivity, which we discussed about the atopic pathogenesis. So this thing need to be kept in mind. Now we will be talking about the diagnosis of asthma. Most important thing to be kept in mind is that most of the cases of asthma, they are diagnosed clinically. How? Because of wheeze, cough, chest tightness, and breathlessness. So you have to keep this in mind. Most of the time it is manifested, it is diagnosed clinically, and you have to keep in mind it is like episodic. isn't it? So while taking history, you have to keep this thing in mind. And there is diurnal variation with exacerbation of symptoms at late nights or early mornings. So these things you have to keep in mind. And there can be like seasonal variation and different other like occupational things and exercise induced asthma. So all these things you have to keep in mind. And there can be certain category, like there can be drug induced asthma, for example aspirin intake, or it can be NSAIDs, isn't it, or it can be like beta blockers. So you have to keep that in mind. So drug induced category of asthma, so that history also you have to be very much cautious to be taken. So episodic, diurnal variation, seasonal variation, and you find clinically there is wheeze, cough, chest tightness, breathlessness, then you can clinically diagnose asthma. And for confirmation you have to do lung function test, and in lung function test we do spirometry. And in spirometry what we can find, first of all let me show a normal, I will first present the normal condition. So I have here one graph. So in x-axis we have volume and in y-axis we have flow. So during normally what will happen, our inspiration will go like this. First of all I will show you the normal one. So this is 0 and 6. So normally what will happen, this will be the inspiration and expiration will be like this. Okay, so this will be residual volume, this will be residual volume, and this whole will be total lung capacity, and this will be inspiration and this will be expiration. So normally it will go like that. But in case of asthma, what will happen is that you will find shift towards the left, and you will find certain kinking here, and this you can see the flow rate is higher in case of normal, but it is lower in case of asthmatic patient, and it will be shifted towards the left, meaning the total lung capacity will be raised in case of asthma, because there will be air trafficking. So because of air trafficking there will be more residual volume, and as a result total lung capacity will also increase. So left shift you can find in case of asthmatic. And here you can see another graph showing volume and time. So you tell the patient to expire. So what will happen, you in normal case you will find graph as like this. So in normal case you will find graph like this, and this point is FEV1, forced expiratory volume in 1 second. But in case of asthmatic patient, what it will take place is that you get graph like this. So you see here the FEV1 ratio is decreased, isn't it? So if you calculate FEV1 by FVC ratio, then it will be less than 70% in case of asthmatic, or in case of obstructive lung disease. So asthma is also the one of the obstructive lung disease. So this graph will help you to diagnose a patient with asthma. And another is peak expiratory flow. So you can do this at home basis also, and it can be done at clinical basis also. So if that is less than, if it is less than 60%, then we can diagnose it as asthma. Less than 60% then predicted. And in X-ray, generally speaking, X-ray is not a sensitive tool for diagnosing asthma, especially in case of acute exacerbation of asthma. But during the initial course of time, you can use X-ray as a tool for diagnosis of asthma. So what will you find in asthma? In X-ray, there can be like patchy atelectasis can be there because of mucus plug, and you can find air trapping. Sorry, you can find ear trapping, and you can find pneumomediastinum, means you can find ear filled, paratracheal, and you can find peribronchial coughing. Why is it so? Because of the ongoing edema and inflammatory process. And lung field can be like increased if there is air trapping. So, and other than this, in case of severe, like if there is ongoing pulmonary hypertension, then you can find like main pulmonary artery may be prominent. So these are the different things which you can see in X-ray. However, the thing to be kept in mind is that these features can also be seen in case of chronic bronchitis, and there can be like viral bronchopneumonia. So you have to be very much cautious while diagnosing it through the X-ray. And as we have already discussed, in case of atopic cases or pollen triggered or allergy triggered asthma, then you can do skin prick test, isn't it? And you can also do bronchodilator response test at the time of symptom. Suppose patient comes to you with bronchoconstriction or breathlessness, then you give him a bronchodilator, let's say SABA. What will you now notice? After giving SABA, if there is increase in the spirometry level, or if there is progress in the FEV1 by FVC ratio, or if there is progress in the PEF, then you can diagnose it. Or alternatively, you can do airway hyperresponsive test. In this test, you can provoke the trigger, and because of release of histamine, you can give the histamine, and you can see there is bronchoconstriction. But this has to be done in very much like in critical care situation must be available, otherwise this is obsolete nowadays. And another thing, it is not the case for diagnosing. However, to like label the severity, you can do cough and sputum eosinophilia test, and if you find this to be high, then you have to be very much cautious that this patient may have risk for exacerbation or asthma related deaths. So these are the different modalities by which you can diagnose asthma. Now we will discuss how to assess the asthma status. Suppose there are three main criteria. One, you have to find the status of the symptom and risk factor. Another is you have to assess the comorbidities, and another you have to assess the treatment. How is the treatment going on? So three things you have to keep in mind always. One, that is symptom, whether it is controlled, partly controlled or uncontrolled, and another risk factor for poor outcomes, and third being your comorbidities. You have to always look at comorbidities, and you have to see whether treatment going on is adequate or not. So we will be discussing these in detail. Suppose if a patient has, so you need to keep track of 4-week time interval, okay, 4-week time interval. So in these 4 weeks, if that patient has more than 2 times day symptom, then this will have 1 grading. Okay, once again I repeat, you have to recall for 4 week, or you can recall for 1 month time period, and in that time period, if the patient has more than 2 times day symptom in a week, then this will get 1 point. If there is a requirement for reliever medication like SABA, or it can be like ICS plus formoterol, so if the reliever medication is required for more than 2 times per week, then again it will get 1 point. And suppose if there is any nighttime awakenings, suppose there is asthmatic episode at night and the patient has to wake up, then it will again get 1 point. And if there is any kind of work or activity limitation, then this will get 1 point. So now in case of controlled asthma, what will be there? None of these 4 criteria will be there. And in case of partly controlled asthma, two of these features can be present. Whereas in case of uncontrolled asthma, there can be 3 or 4 features. So by recalling the 4-week time period interval, if the patient has 2 times episodes, more than 2 times episodes weekly, or more than 2 times reliever medication required per week, or more than 1 nighttime awakening, or any kind of work limitation, you have to filter it out and you have to give the ranking. And if under that, if none of these, it is controlled. If there are 2 of the symptoms, it is partly controlled. If 3 or more, it is uncontrolled asthma. Now second step, what you do is you assess the risk factor for poor outcomes. Suppose in a year there has been severe exacerbation, then this is the risk factor for poor outcome. Suppose you find there is recent need of oral OCS, oral corticosteroids, then you can think, because if that patient is requiring oral OCS or oral corticosteroid, then this means that the symptom was severe. So you have to keep in mind, oh yes, this patient is risk factor, or this patient is having risk factor. So we have to think that in mind. And if the patient is a smoker, then this is the sole cause for causing severe exacerbation. And in case of neonates or in case of children, if there is PICU admission repeatedly because of bronchoconstriction and breathlessness, then you have to think again. And another thing about the SABA treatment, SABA generally previously it was extensively used as a reliever medication. Now also it is used, but one thing you have to keep in mind, too much of SABA is not to be used. Suppose the patient is using more than 3 canisters per year, then this SABA medication will increase the likeliness for allergic manifestation, and there will be like airway inflammation will be more, and when there will be like severe episode, then at that time SABA will not be much effective. So this is the limitation. So this will ultimately give rise to risk factor for poor outcome. And if the patient is using more than 12 or like 10 to 12 canisters per year, then this will ultimately telling us that the asthma is not properly managed, and this will give rise to poor outcome, that is asthma related death. And now you have to note the comorbidities. Are there any comorbidities or not, like obesity, or if the patient has anxiety then depression, then the adherence may be poor. And in case of pregnancy, we must be cautious, we have to manage the disease. And in case of different exposure, suppose there can be indoor pollution, if there can be outdoor pollution, there can be air pollution. If that exposure is going on, but you are giving the medication but exposure is not controlled, then there is no use. So you have to limit the exposure too. And if there is features of GERD and chronic rhinosinusitis and polyposis, so you have to keep in mind that asthmatic patient may also have upper respiratory tract infection, frequent infections, and if there is viral infection, then this can lead to exacerbation. So these things you have to keep in mind. Okay, and now you have to check whether the treatment is adequate or not. And here I have put regular ICS use or not. Suppose chronic low dose ICS as a reliever and maintenance therapy has proven benefit to reduce the risk of exacerbation over to SABA. So you have to keep that in mind. And whether the technique is good or not, adequate or not. Suppose you say that person is taking meter dose inhaler, but he may not be taking it properly, he may not tilting his head, or the technique may be wrong. So you have to check the procedure as per the labeling of the device, and you have to check that in front of you when the time of visit, and you have to check whether they are doing it properly or not. If they are doing any mistakes, you have to tell them, and as per that again we have to recheck whether he is doing again correctly or not. An adequate dose, most of the time they use empty canisters and they keep on puffing and puffing, but the canister is empty. So you have to think about this also, and whether there is adherence or not. So you have to ask very much like politely in a healthy friendly relation. Suppose you can start like this, that most of the patients find it difficult to be adherent to the medication. So do you find any such difficulties or not? So you have to ask them gently, and you have to know their adherence status. And another thing is step up and step down approach. Suppose the symptom is aggravating and the medication is not working, you think so, but first of all you have to check whether the technique is good, adequacy is there or not, and regular intake is there or not, and then you can step up, you can move for higher doses. And suppose in higher dose level or step 3 or step 4, suppose the symptom has subsided for more than 3 months, then you can think of gradually decreasing down, looking at the lung function test. So in this way you can find whether the asthmatic patient is controlled, partly controlled, or uncontrolled. Now we will discuss the treatment modalities of asthma. So I have drawn here two diagram. and it is based upon GINA guideline 2021, and I have presented here track 1 and track 2. So there are two modalities of treatment for asthma. One is track 1 and one is track 2. In case of track 1, low dose ICS and formoterol is used as reliever medication. So you have to keep that thing in mind. Low dose ICS and formoterol is used in combined form in case of track 1 as reliever medication, whereas in case of track 2, SABA is used in case of is used as a reliever medication. Now, one thing you have to keep in mind is that during recent publications, GINA guideline has given more preference towards the ICS plus formoterol combination. The reason being is that use of SABA has predisposed more chances of severe exacerbation, and frequent episodes of SABA uses have shown that there is increased like allergic responses, increased inflammatory mediations, and at the time of severe exacerbation, the SABA is not so good to abolish the episode. So because of that, SABA has been discouraged in recent editions. Okay, now let us discuss. And these two modalities are important, or these two modalities are for adult age group, and in adult age group and adolescents, these two therapy is used. Adolescents greater than 12 years. So these two modalities can be used. It can be track 1 and track 2. So let us first discuss track 1. As I have already told, in track 1, low dose inhaled corticosteroid and formoterol is used as reliever medication. So in step 1 and 2, so what are the conditions for step 1? So in step 1 and 2, the patient will have less than 4-5 days symptoms per week. So in a week, they will have only 1 or 2 daytime symptoms. So in that case, you can use low dose ICS and formoterol as on required basis. However, recent GINA guidelines tell us that if you diagnose a patient with asthma, then you have to prescribe him or her for low dose ICS. However, because of not adherence, so people usually prefer to use as needed basis. So in step 1 and 2, you can go in that way. Now in step 3, suppose if there is more than 2 daytime symptom per week, and if there is more than 1 or equal to 1 nighttime symptom per week, then at that time you can go for step 3. What happens in step 3? Now you use low dose ICS and formoterol as maintenance and reliever therapy. So this is called as MART. So in this case, in step 1 and 2, you were using low dose ICS and formoterol as needed basis. Suppose if the patient is symptomatic, you will use low dose ICS plus formoterol combination. But in case of step 3, in this condition, what will happen? He will use MART therapy as maintenance as well as symptom reliever. Now in case of step 4, so in which case step 4 is used? Step 4 is especially used in case of uncontrolled asthma. In case of uncontrolled or partly controlled, let's say partly controlled and severe asthma, you start with step 4. So what happens in step 4? You give medium dose ICS plus formoterol. In step 3, you are giving low dose. In case of step 4, you give medium dose ICS plus formoterol. And in case of step 4, sometimes there may be the requirement of oral corticosteroid for some days. So you have to give oral corticosteroid for 5 to 7 days. We will discuss that in case of acute exacerbation in more detail. But for now you keep in mind that medium dose ICS plus formoterol is used. And in case of step 5, suppose if it is not adequately managed here, and one thing to be kept in mind is that during step 3 and step 4 process, there are other modalities you can try. Suppose you can give anti-leukotrienes like montelukast, zafirlukast, isn't it? And you can also try for chromonil, sodium chromonil, which is mast cells stabilizers. So if those medications does not work in these steps, then what you need to go, you have to go for track op objective way. So if step 3 does not proper, if there is no suppose in step 3 I started a patient in step 3 and he is not getting relief. Suppose I started therapy, I call him after 1 week or after 1 week, and then I assess him, and then it is not going well. Then what I need to do, first of all I need to check for the adherence, then I need to check for the proper technique, then I need to check whether the dose is adequate or not, and I need to exclude if there is any kind of exposure factor or not, if it is smoking or any dust pollution, indoor outdoor pollution or not, and if there is any comorbid conditions like obesity, anxiety, depression. So all those things I need to keep in mind, and if all those things are negative, then I go for step 4. Likewise, if step 4 does not work, I go for step 5. In step 5 we can go give long acting muscarinic drugs, and in case we can also give omalizumab, that is anti-IgE, and we can give recent medications like anti-leukotriene 4 or 5 receptor, or you can prefer for high dose ICS plus formoterol. So this is the treatment modalities that we take consideration in track 1. Now let us discuss track 2. What happens in track 2? In track 2 we have already discussed SABA is used as what? Reliever medication. SABA is used as reliever medication. Now in step 1, what will happen? In step 1, suppose the criteria is that suppose the person is having less than 2 times symptoms per month, then we keep him in step 1. And this step 1 case, what we do, we give SABA as per required basis, and while giving SABA we also give low dose ICS along with that. However, in case of step 2, suppose the person has symptoms more than 2 times per month, however it is less than 2 times per week, then we place him in step 2. And in step 2, what we do, we give low dose ICS regularly as maintenance dose. We give low dose ICS and we give SABA as per required. Suppose if there is exacerbation, then we give SABA. In step 3, what we do, we give low dose ICS plus LABA as maintenance dose, and we give SABA as on per required basis. What we do in step 4? In step 4, we give medium or high dose ICS plus LABA and SABA as per required basis. And step 5, as same as the previous one, LAMA, anti-IgE, and high dose ICS and LABA. So the main difference that you have to keep in mind is that in track 1, we use low dose ICS and formoterol as reliever medication. In track 2, we use SABA as reliever medication. And one thing you need to keep in mind that if suppose step 3 is not working quite adequately, then you have to check adherence, you have to check the inhalation technique, you have to check the correct dosage form, you have to check the risk factor, you have to check the comorbidities, and keeping all those things in mind, if they are negative and you do the pulmonary function test and it is worsening, then you need to go for step 4. Suppose if he is in step 4 and it has been like 3 months that he is not having any symptoms, then you need to do pulmonary function test, you need to assess all those techniques, all those comorbidities and all those factors. If they are okay, then you can slowly gradually step down to step 3. So these are the modalities for going step up or step down. And another thing you need to keep in mind is that, as I have already told, in track 1, low dose ICS and formoterol is used as reliever medication. However, in track 2, SABA is used as reliever medication. You can interchange these reliever medication while going up and down the track. But one thing you need to keep in mind is that suppose the person is using ICS and LABA, suppose ICS and salmeterol, then you cannot use ICS and formoterol. In that case, you have to use SABA only. So that thing you need to keep in mind. Otherwise, reliever medication can be interchanged while moving up or down the track. So you have to keep that thing in mind. So this is the treatment strategies for adult and adolescent age group. Now we will discuss what is the treatment modalities for children, especially 5 to 12 years of age. Now we will be discussing based on GINA guideline for treatment of asthma in case of children 5 to 12 years of age. Now there are 5 steps. We will discuss from step 1. Suppose the child is symptomatic less than 2 times per month, then you can give SAVA as per required basis, and during that use of SAVA you also give low dose ICS. Now in step 2, if the symptom is more than 2 times per month or it is less than 2 or equal to 2 daytime symptom per week, then we go for step 2. And in step 2 what we do is that we give low dose ICS as regular maintenance dose and we give SAVA as per required basis. Now in step 3, if it is partly controlled asthma, suppose there is more than 2 time day symptom per week or there is more than 1 or equal to 1 nighttime symptom per week, then we go for step 3. In step 3 we have 3 modalities. 1, you can give low dose ICS plus LAVA, or you can give very low dose ICS plus formoterol, or you can give medium dose ICS. Now in case of low dose ICS and LAVA, you use this as maintenance dose and you give SAVA as per required basis. In case of medium dose ICS also you give SAVA as per required basis, but in case of very low dose ICS and formoterol, it is used as MAT therapy. Suppose if it is uncontrolled or severe asthma, then we go for step 4. In step 4 there are 2 modalities of treatment, one being medium dose ICS plus LAVA and another being low dose ICS per formoterol. And step 5, anti-IgE, omalizumab and high dose ICS plus LAVA and anti-leukotriene and phenotropin and so on. But the thing to be kept in mind is that to understand this, you need to think that step 1 and step 2 are same as GINA guideline, which is used for adult and adolescent, and in case of track 2, because in track 2 we use SAVA as reliever as per required basis. So you can think of that step 1 and step 2, they are same as track 2 in case of adult age group. However, in case of step 3 and step 4 there are some differences, but you see the use of ICS and LAVA, they are same as in case of track 2. So you can correlate this with that. So we have now talked about treatment of asthma in case of 5 to 12 years of age. But what about less than 5 years of age? First of all, we need to think about the differential diagnosis. Differential diagnosis of bronchial asthma in case of children less than 5 years. So the first and foremost differential diagnosis being that is acute bronchiolitis. So because of respiratory syncytial virus, acute bronchiolitis is more common in case of children age group being 6 months to 3 years. So during first year of life. So this is very much common in case of pediatric age group. So this is one of the differential diagnosis of bronchial asthma. But the thing to be kept in mind is that recurrent bronchiolitis can predispose to asthma. Especially 50% of cases of acute bronchiolitis which are recurrent in cases, they result in asthma. Though respiratory syncytial virus is the most common causative agent for acute bronchiolitis, the rhinovirus induced acute bronchiolitis is in research is has found that this rhinovirus has more tendency for causing severe exacerbation of asthma. So you need to keep that in mind. Another differential diagnosis is foreign body, and another differential diagnosis is cystic fibrosis, and another differential diagnosis is reactive pneumonitis. So these differential diagnosis in case of pediatric age group less than 5 years you have to keep in mind. And while diagnosing a patient with bronchial asthma, you need to keep in mind like reactive bronchitis and reactive airway disease, eosinophilic bronchitis, and if there is recurrent episode, then you can label the baby as asthma. But generally you don't label as such in single or 2 episodes. So if it is recurrent and the baby is being relieved from regular use of nebulizers, then regular use of bronchodilators, then you can label that baby as asthmatic. However, generally speaking, if the baby comes with respiratory distress, then you go for bronchodilator, and if the bronchodilator works, then you leave the baby. In some cases, there can be need for steroid therapy also, and you can give low dose ICS as maintenance therapy for 2 to 3 months, and then you can discontinue it based on the relief of symptom. But if there is recurrent episodes and baby comes to you again and again with the same features, episodic in nature, then you can label that baby as bronchial asthma, and then you can treat them as per this guideline, which is used for 5 to 12 years of pediatric age group. Now we will be discussing a very important topic, that is management of asthma flare-ups. I have used the term flare-ups because GINA guideline to 2021 tells us that the term exacerbation is to be less used, especially in front of the patient, because it can give different meaning to the patient and they may perceive it differently. Now, first of all, let us talk about the home management. And in home management, I focus on written asthma action plan. Suppose you start a person or a patient for asthma medication, then every time he visits, you must be assured that he has a written asthma action plan, which is especially helpful in case of severe exacerbation during at home time. So in that written asthma action plan, what the physician tells or writes down is that what are the things to be done, and he reassures that the patient has understood it, and by doing so, the tendency that the severeness of the exacerbation and the timely referral to the hospital by the patient himself will be adequate enough to save a life. So that is the main purpose of written asthma action plan. So the first and foremost being, suppose you find a patient with seasonal attacks, then you can tell him or her that he can slowly increase the controller dose, or any patient if he has controller dose, if any patient if he has like building up asthma attacks and it is mild and moderate in grade, then you can slowly gradually you can increase the controller dose, and that patient can increase the reliever dose as per the required basis. However, the patient must be clever enough to review his or her symptom. Suppose now if he has reviewed his symptom, then he finds that the symptom is improving, then he can be static for increasing the reliever and controller dose for some weeks, and then he can slowly have a visit to a doctor. However, if he finds that the symptom is not adequate enough and it is not relieving, and in 48-hour time interval if he finds his PEF less than 60% than it should be, then he must be using regular reliever and control, increasing the dose, and he must also take oral prednisolone, which is 40 to 50 mg for adult and 1 to 2 mg per kg in case of pediatric age group, and he must immediately refer to a hospital and visit a physician. So in case of severe and if the symptom is not subsiding, and after increasing the reliever and controller dose, the patient find that the symptom is not improving, then he needs to take the oral prednisolone and he needs to visit the doctor. So this is the format which is being told and written in case of written asthma action plan. So now we have talked about increasing the reliever and controller dose, but how much to increase? So this is the important thing, and how the patient can be reassured whether his symptom has subsided or not. Suppose if the patient is on track 2, in track 2 what we use SABA as a reliever medication. Suppose there is a need of SABA again in less than 3-hour time interval, then the patient must be conscious that yes, my symptom is not resolving properly, now I need to go to visit my physician. So this hint will tell you. And another thing, if he is using ICS plus formoterol, suppose he is using ICS as separate dose, then what you can do is that you can easily quadruple the dose. So we have talked about increasing the controller dose. So you suppose if the patient is taking X gram of ICS, then he can use 4x gram of ICS during the home stay when his symptom is increasing. However, formoterol, you can use this ICS plus formoterol. Basic concept is that suppose if it is beclomethasone, then you have to use it. Suppose if it is more than 8 times per 24 hours, then you need to think that the symptom is not managed well. And if you are using budesonide, then you can use up to 12 times per 24 hours. So if you are using more than this, and if more than in less than 3 hours SAVA is again required, then you need to think that your symptom is not subsiding quite well, and then you need to take oral prednisolone, and you need to immediately visit to the hospital or a physician. So this is the way how home management of the asthma takes place.